This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here this morning with Dr. David Milia, one of our CSAP 17 authors. Dave, can you share with our audience a little bit about yourself, like where you're located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or week, if there is one of those?
Absolutely, Dr. Weigelt. Again, my name is David Milia. I am a trauma surgeon with the Division of Trauma and Acute Care Surgery at the Medical College of Wisconsin. I have been a surgeon here for approximately 10 years, and I currently serve as the Trauma Medical Director for Brainerd Hospital's Level 1 Trauma Program.
And what do you do on your usual day?
We split our time between the three primary services, being emergency general surgery, our trauma service, as well as our surgical critical care service. I divide my time clinically between those three practices with a small general surgery practice interspersed. And between that and my role as the trauma director, which is primarily in a performance improvement role these days, my days are pretty well booked.
I bet you they are. So, well, let's move on, and I've asked you to share some of your thoughts regarding topics from the trauma category of CSAP 17. Most of the topics come right from CSAP 17 questions, and others will be from questions that were written, but not necessarily selected for the final draft of CSAP 17. Yet I remember them as questions that were discussed by many of the committees, so I'd like to get your ideas on your thoughts on many of them. So anyway, that's my plan, and let's get started. Let's first start with some questions that relate to your military experience that you didn't mention, and just want to make sure that I thank you for that. And many times we don't discuss a lot of the military experience in CSAP, but I think this time we've done a pretty good job. And I just want to, I guess, publicly to our audience, thank everyone who has served in our armed forces over the last few years and in our past. Actually, there's an anniversary coming up, if I remember right. The Doolittle raid is coming up pretty close. So history continues to repeat itself. Let's talk about tourniquet use for first responders, whether public or police. And certainly the Stop the Bleed program has produced a simple device to use. But are there any other devices that one might improvise as a tourniquet from the standpoint if you're there and you've got somebody that you think needs a tourniquet? Are there effective devices that we could employ?
John, that's a great question. If you look back at the tragedy that occurred during the Boston Marathon, most of the tourniquets that were employed following that catastrophe were homemade tourniquets. People used scraps of cloth or their belt, and what we found was that the majority of those homemade tourniquets were ineffective. I think what people sometimes fail to realize is the amount of circumferential pressure necessary to obstruct arterial inflow. And really the only way to get that amount of torque from a cloth or a strap wrapped around an extremity is to somehow recreate the windlass or the corkscrew or the stick, essentially, that is able to really tighten down a tourniquet in a circumferential fashion. And so, although it is possible to create a homemade tourniquet with a cravat or a bandage and then some sort of durable piece of plastic or metal rod, this does take practice, and it's not as easy as everybody thinks it is.
I remember from my first aid training about 8 decades ago that the idea there was to put the cloth on, but without a stick or something, as you said, to tighten it up. It was pretty inefficient, just as you mentioned. Now, I have another question because there was a question in CSAP about using sequential tourniquets, and that was better than a single tourniquet. Is that something we should be promoting?
We do find that, especially in lower extremity penetrating trauma, that one tourniquet can at times be ineffective at reducing 100% of the arterial inflow. However, a single tourniquet can reduce the pressure head by as much as 60 or 70%. And so a second additional tourniquet placed immediately adjacent to the primary tourniquet that was placed can often effectively completely reduce arterial inflow to the extremity. Again, we see this mostly with lower extremities and in people with larger thighs. Just in order to get that circumferential pressure, occasionally two tourniquets are needed.
The other thing I've noticed is we have talked a lot about putting them on, just like we did now, but what should we do, or what should a physician do when a patient arrives in the emergency department and has a properly placed tourniquet in place?
Yeah, I find it amusing you say properly placed. What I've noticed at our urban level 1 trauma center is the overwhelming majority of the tourniquets, which are primarily placed by emergency medical responders and not civilians, are ineffectively placed. And so the first thing I would do would be to assess whether or not there's a distal pulse. If there is a pulse, one can assume that the tourniquet is not really accomplishing much, and if there's no active bleeding in the presence of a pulse, the tourniquet can generally safely be taken down. A general assessment of the patient's status as well as your own capabilities is necessary. We need to recognize that if patients are coming in and they're hemodynamically abnormal or were victims of a multi-system trauma, that tourniquet may be the only thing preventing them from having catastrophic physiologic problems, including a massive hemorrhage. And so if you are at an institution and you don't have the ability to care for major vascular trauma, or your surgeons are not immediately available, I think the tourniquet needs to be left on until a formal assessment of the remainder of the patient is performed.
Okay, you picked up on that really good that I said properly placed. And so you're right that the first thing you do is check for the pulse, and if it's there, and the patient's not bleeding out in front of you, you have a pretty good idea the tourniquet's not necessary. However, let's talk about the case where you evaluate the patient. You're the surgeon at the bedside. There is no pulse. The tourniquet is in. The pre-hospital providers say, oh, yeah, it was actively bleeding until we put the tourniquet on. What's your next step?
In my shop, as a trauma surgeon who's comfortable with vascular injuries and at an institution where I know we can handle it, for patients who are relatively hemodynamically normal and aren't otherwise injured, I will take the tourniquet down in the resuscitation bay. If I immediately encounter hemorrhage, I can put the tourniquet back up and take the patient to the operating suite. If the patient is physiologically deranged, secondary to their extremity trauma, the tourniquet needs to be left on, recognizing that waxing, waning, hypotension, normotension, hemostasis, and bleeding is associated with increased mortality in our patients. The other patient population I think it's important to talk about is the multiply injured patient. For patients with multiple penetrating injuries, i.e. extremity, truncal, and potentially thoracic injuries, I think having a well-placed, appropriately placed, I should say, tourniquet in place allows us to, and I use this word cautiously, allows us to ignore that injury while we work up the other potentially more critical injuries. And so if we have hemostasis on an extremity due to the tourniquet, we can table that injury for a couple of minutes while we evaluate the remainder of the injuries.
You're sort of implying that life over limb plays a role in your assessment.
That's correct.
Okay. I want to retrace the comments here. So when you have a patient who is hemodynamically unstable or abnormal, and the tourniquet is up, there's no bleeding, you let the tourniquet down to see if the bleeding occurs and before going to the operating room, or do you resuscitate the patient, see what happens before going immediately to the operating room?
For the patients that are physiologically abnormal or hypotensive or in obvious or demonstrable hemorrhagic shock, I will resuscitate those patients in the trauma bay with the tourniquet up. If they prove to be a responder, a durable responder, depending on the injury pattern, I may take that tourniquet down and see if there is arterial hemorrhage. If they demonstrate that they're only a transient responder or a non-responder, then I will take the patient to the operating room while ongoing resuscitation is in place.
Well, now that you've mentioned resuscitation, let's talk about it a little bit. And a lot of our approach has been challenged or changed, you might say, based upon data from the military. Crystalloid is now downplayed and blood is emphasized. From a practical standpoint, for most of our audience who don't live in a high penetrating injury area, what does that mean to them for their approach to resuscitation today?
Yeah, this is an important topic, Dr. Weigelt. I do state reviews for the lower level trauma centers in the state of Wisconsin, and having blood and blood products available can be extremely resource intensive for these hospitals. However, that said, for institutions that are going to be seeing any trauma patients, having some sort of massive transfusion protocol in place is absolutely necessary. Now, what that protocol looks like is going to vary from institution to institution. And to be honest, I've seen some really creative workarounds for some of our resource-stressed or resource-poor hospitals in the state. But having that protocol in place and drilling it and practicing it prior to the arrival of our sick patients is extremely important.
So the fact that the majority of data was generated on penetrating wounds, and in the civilian world, most people deal with blunt mechanism wounds. Does that impact how we apply this data?
We've looked at the data on the civilian side enough, and we've recognized that over-aggressive crystalloid resuscitation for our patients that are, again, in hemorrhagic shock is detrimental, and we do need to find a way to perform a blood product early resuscitation for these patients.
So when we talk about blood administration, a lot of talk about what's the right ratio. Is that as important as some people would imply?
I think it's important to an extent. As we talk about the triad of death, or the lethal triad in trauma, which includes coagulopathy at one of the vertices, we need to recognize that giving somebody only red cell mass or only packed red blood cells in ignoring the ongoing coagulopathy that occurs with trauma can be detrimental to our patients. In fact, most patients don't die of acute anemia. They will die from a shock related to the coagulopathy that occurs with ongoing trauma. So I think early plasma administration is extremely important. Ratios on the order of somewhere between 1-to-1 and 1-to-2, I think, should be the target for most institutions. The largest study to date that tried to tease apart a difference between 1-to-2 and 1-to-1 showed a decreased mortality due to hemorrhage in the 1-to-1 group. However, there was no overall mortality difference between these two ratios. We do know that ratios that are as far out as 1-to-4 may increase mortality for patients, though.
Okay, well, you've talked a lot about coagulopathy, and we have a drug now that seems to be a favorite in the trauma world, and that's TXA, or tranexamic acid. And let me ask you first, do you use it routinely?
We do have TXA as part of our massive transfusion protocol. We employed it based on the data from two large studies. One was in the military side, and the other study was in the civilian side. I'm not as much of a TXA zealot as other people are. I think the best data that we have on the civilian side is weak at best, and that we're extrapolating a lot of data from the military folks. There are some new studies coming out, hopefully within the next couple of years, that will try to elucidate the true benefit of giving empiric TXA. Now, that said, we do use rotational thromboelastography at our institution, and for patients who have demonstrated hyperfibrinolysis, I think TXA is an important drug. But again, that's using it in a directed fashion and not in an empiric fashion.
Have you seen creep into the field for TXA in your area of the country?
I think creep may be the biggest understatement of this entire conversation. I think I see more and more pre-hospital folks using TXA, thinking that it in itself is a blood product, or it in itself completely replaces other like plasma or other blood products that are necessary for resuscitation. I don't know that we have the best data to widely be employing TXA as much as we do. There's a large prospective observational study that us and 15 other major trauma centers are part of, looking at VTE, venous thromboembolism, and all of the factors surrounding it. And I do wonder when this study is finally published in the next couple of years if we're going to see an increased clot burden from patients who get sometimes inappropriate use of TXA in the field.
Well, you've already mentioned directed use using ROTEM or TEG, and I have another question for you, which you must have thought about under those circumstances, and that is, for those of you that are using it, ROTEM or TEG, it appears to be that primary hyperfibrinolysis is not the predominant profile in our massively injured patients or patients who are candidates for a massive transfusion. Do you have any comments about that?
Yeah, at the risk of getting into the weeds a little bit, I think it's a fascinating topic and warrants a discussion. We do see hypofibrinolysis, or it is noted that in patients who have hyperfibrinolysis, they have a much higher mortality rate than patients who don't demonstrate hyperfibrinolysis. However, the percentage of trauma of severely injured patients that do demonstrate this TEG finding is very, very small. The other patient population we do see, though, however, and it's less well understood, is the patients who have fibrinolysis shutdown. It's the opposite problem. And these patients also seem to demonstrate an increased mortality, but we're not really sure why. We don't really know the ins and outs of this. And we also think this population may be at increased risk for very early de novo pulmonary embolism and other VTE events.
And TXA wouldn't be very good for those people, would it?
TXA would not be very good for those people.
Okay, I still remember some things. Every once in a while I forget some things. So, okay. Let's talk about your massive transfusion protocols. And I've already asked one of your colleagues from CSAP in his trauma interview about the use of MTP and how they decide when to use it. And there's about a dozen scoring systems that have been propagated with the idea that we can better predict the patient who needs a massive transfusion. Do you use one of the scoring systems before you implement a massive transfusion or any type of assessment?
We do use one of the simpler scoring systems, the ABC score, as it's often referred to, and basically we ascribe 1 point for hypotension, 1 point for tachycardia, and then 1 point is assigned somewhat mechanistically, either for penetrating thoracoabdominal or truncal injury or a pelvic fracture or positive FAST exam. Patients who have 2 out of 3 points will have about a 80 to 90% percentage of needing a massive transfusion. The scoring system is okay. It has a really good negative predicted value. In other words, patients who only have 1 point in general will not need a massive transfusion. However, using this system does overcall the need for a massive transfusion. And if I go back, because I'm responsible for doing the performance improvement here, when I go back and look at the patients who have a massive transfusion started, only approximately a quarter to a third of them actually go on to be massively transfused, so to speak. And so using these scoring systems can be a little bit resource intensive for institutions where blood and blood products are of limited availability.
And your definition of a massive transfusion protocol is what these days, since it seems to wax and wane?
It does wax and wane. I am a big fan of the time-dependent definition, which looks at 3 units of blood product administration in under an hour. However, the classic definition of 10 units in 24 hours is still utilized fairly frequently in the literature.
You've mentioned the smaller hospitals a couple of times without a blood bank, or at least not a large blood bank. When you go review those hospitals, you said they have lots of different workarounds. Have you heard one that makes a lot of sense?
Yeah, one of my favorites, and I actually take this one with me when I go visit other hospitals, is It has to do with the fact that most smaller hospitals cannot maintain a stock of plasma, of thawed plasma, and they have to actively thaw plasma for patients who require administration. We at our institution are fortunate enough that we're such a high utilizer that we can maintain thawed plasma available at all times. So there is a limit to how fast one can thaw a unit of frozen plasma. And this is just basic physics. It's how fast can you melt an ice cube, basically. What I found at one institution a little bit north of us was they, instead of stocking adult units of plasma in their freezer, they actually stocked pediatric bags, which are about half the volume. And some basic physics teaches us that they will thaw twice as fast. And so this hospital was actually able to thaw twice the number of pediatric doses much more rapidly than they could thaw the same number of adult doses. And I thought this was a fantastic workaround for this shop. It just showed some creativity that I hadn't seen, or we don't see in patients that are in institutions that are resource rich.
That's very interesting, very helpful. On another related topic, I just spoke to another one of your colleagues, actually from the University of Pennsylvania, and they now have the ability to use fresh whole blood in their massive transfusion protocol. And I know you've got a pretty active blood bank in Milwaukee, so I would ask you, have you thought about having fresh whole blood for your massive transfusion protocol?
Do you mean fresh whole blood, or do you mean banked or stored whole blood?
I mean, relatively fresh whole blood was what I was told. Okay, how's that definition?
I think we need to be careful because in the military, we are able to utilize walking blood banks. And so during our times of massive casualty, we use the freshest whole blood available in that we are able to draw from one soldier and turn that blood around and administer it immediately to another soldier. What most institutions that are using whole blood as part of their trauma resuscitation are using, they're using cold stored whole blood. Now it may be relatively fresh, but it is cold and stored whole blood. We have adopted a whole blood protocol here as part of our massive transfusion. We use a low titer O positive whole blood due to its higher availability than O negative whole blood. Because we are only using O positive whole blood, and we're only administering it to males and women of non-childbearing age. We began this approximately a year and a half ago, and we started with a system of giving only 4 units of whole blood as a maximum to our patients in a massive transfusion setting. We've had no events of lysis or transfusion reaction, and so since then we've upped it to, we can go up to 6 units now per patient. The data on the civilian side are weak so far. We haven't seen the robust outcomes that the military has demonstrated to us, but I think we're early in the process and we just need to study this more. There is a little bit of a signal that there may be a decreased transfusion requirement for patients who receive whole blood as part of their massive transfusion.
I just have a very practical, almost silly question though. So when all is said and done and your MTP is through and you're calculating your ratio, how do you calculate the ratio for a unit of fresh whole blood?
I calculate that as a 1-to-1-to-1 ratio, and that is a complete workaround, Dr. Weigel. In fact, I will say that TQIP, as of right now, does not have a field for whole blood. Now, that said, in going into 2020, they are going to be adding a field for whole blood. So we had to develop a place in our registry to actually record it, because if I recorded it anywhere else, it was going to look kind of funny when I went back and looked at the chart. So we are a little bit ahead of the curve. The number of the institutions in our country and worldwide that are giving whole blood as part of their protocol is still low. I think it's about 20 at last count. I think there will be wider adoption as we go forward, and hopefully with wider adoption, we can generate the appropriate studies that will show us efficacy.
Well, maybe your workaround for your ratio will be accepted. We'll call that the Milia adjustment. All right, let's move on a little bit. So let's talk about clearing the C-spine. How do you do it in an awake patient?
In the awake patient, we use the Canadian C-spine rule. There are 2 fairly well accepted ways to clear cervical spines in awake patients. The one was by the National Emergency X-ray Utilization Study Group, NEXUS as they're referred to, and the other was a different group from our neighbors to the north. They're both relatively similar. They involve making sure your patient is awake and examinable, evaluating for any neurologic changes, demonstrating that there is not any midline neck tenderness, and then as long as the patients aren't distracted by another significant injury and they can focus on their neck, we are able to remove the collar and see if they have any pain with active range of motion. The only difference between the two guidelines is that the Canadian C-spine rule, which we use, includes some mechanistic criteria, high-speed motor vehicle crashes, there is an age criteria, non-ground level falls or falls from a height. And for patients with these higher energy mechanism criteria, they get axial imaging or CAT scan imaging prior to clinically clearing them.
What do you say to your colleague who comes by and says, well, if they have a distracting injury, that they can never really be clinically cleared?
Well, I like to employ my circular definition of a distracting injury, and I tell them that basically a distracting injury is not defined by the injury itself. A distracting injury is an injury that distracts a patient from their neck. And I've seen patients who have a hangnail and are unable to focus on any other part of their body other than their hangnail. And I've also had patients who have open femur fractures who are able to tell me, yes, my femur hurts like a son of a gun, but my neck doesn't hurt at all. And they are calm and collected and can tell me that their neck doesn't have any pain. And so I think it really is going to be a patient-specific injury pattern, whether or not they are actually distracted by their injuries.
And so it's a clinical decision aided by some mechanistic parameters.
That's correct, yeah.
Okay, all right. Now, what if the patient's comatose? Can we clear that spine in any way, or do we have to leave the collar on?
We can and should attempt to clear these patients radiographically. In 2015, the Eastern Association for the Surgery of Trauma came out with a very comprehensive guideline for C-spine clearance in the obtunded patient. And what they really aimed to do was to weigh the risks and benefits of leaving a collar on a patient for a prolonged period of time versus utilizing the CAT scan to clear the C-spine. And what they were able to determine was, with a certain amount of certainty, that the addition of an MRI to a normal CAT scan is so minimal, it's so low, that the risk of leaving the collar on for risks of submental or occipital decubitus ulcers or airway issues, et cetera, that those risks actually outweigh the risk of a missed injury, given that a negative CAT scan with both axial, sagittal, and coronal views is nearly 100%, has a nearly 100% negative predictive value. I will say that not everybody agrees with this guideline. However, the data presented are quite good at this point, and the guideline is definitely worth reading. It talks about very rarely do we ever ask for a second screening test if we have one screening test with a near 100% negative predictive value, and I think that the point is very well made. We need to trust the data, and we also need to recognize that restricting motion in the spine and keeping a collar on for essentially no reason does have detrimental effects.
And if I remember that guideline correctly, it truly mentions that it's a helical CT scan with at least 16 slice capability. Is my memory correct?
They specify exactly what you said, 16 slice or up, helical or multi-detector CT array, and they mention from the occiput to T1, and then all three views, like I said, axial, coronal, and sagittal imaging. All of those components must be met.
Have you been successful in selling this approach to your neurosurgeons and spine physicians?
Up to a point. The only caveat that we have made is that our neurosurgeons felt very strongly that for patients with certain chronic findings on their cervical spine, that those patients are at increased risk for a direct cord injury that may not show up on a CT scan. So for our patients with moderate or severe cervical stenosis or ankylosing spondylitis, those patients, either we wait till they are non-obtunded if we can, or we will obtain an MRI in those patients. That was the middle ground that we achieved with our neurosurgeons.
I think that's very helpful. Let's move on, though, and talk about a related topic, and that's TBI. And there were a lot of questions on TBI and CSAP-17. And first, let's talk about mild TBI or concussion. How about a football player is down and out but arouses easily? What should be done to assess that patient?
Well, I think mild TBI or MTBI, this is a huge problem because this is the overwhelming majority of the TBIs that we're going to see. And it can be extremely resource intensive if we feel that we need to radiograph all those patients. And it is not an insignificant amount of radiation to a potentially young population. So fortunately, there is a grading system for our mild closed head injuries or mild TBIs. Grade 1 is essentially confusion only. Grade 2 shows some associated amnesia, and grade 3 shows an associated loss of consciousness. And so for patients with a grade 1 kind of concussion or a grade 2 with just a little peri-event amnesia, those patients can be sent home from the emergency department as long as they have somebody that can look after them or take care of them. For patients with anything more than that, or with ongoing symptoms of headache or nausea or dizziness, those patients should be imaged at that point.
And the imaging is brain CT?
Brain CT would be the image of choice, correct.
Okay, and once that is done, long-term management, any different in those three classes?
I actually don't know that. To be honest, most of these patients are seen by the emergency medical physicians and never make it to the trauma service. But I will say that brain rehab, just like rehab for any other part of the body, is critically important. And we do find that students with these mild traumatic brain injuries may actually require academic accommodations for a fairly extended period of time. They're going to have alterations in their sleep. They may show impulsivity or moodiness more so than a normal teenager. They may have headaches, which may last weeks or months. And so it really is important for the school social support team to know when these events happen so they can accommodate these patients. As an aside, my wife is a high school teacher, and this does happen with their high school football and soccer players. And several of the students have special accommodations or individualized learning plans for a period of time after mild traumatic brain injuries from the sports events.
Let's up the ante a little bit. And a patient is in a motor vehicle crash, GCS of 10. The brain CT scan is negative for any abnormality and no other injuries are found. But the patient wakes up pretty normal 3 days later. Do you do anything to assess cognitive damage in those patients?
I don't personally, but we do. We obtain a neurocognitive rehabilitation consult for every one of these patients. These patients often require follow-up in a brain rehab or a neurocognitive rehab plan or program, just like somebody who would have a severe orthopedic injury who would require physical therapy as an outpatient. We have found that utilizing neurocognitive rehabilitation for post-traumatic brain injured patients does improve long-term outcomes with respect to, again, memory, impulsivity, and other symptoms as well.
Well, let's talk about some specific injuries. Let's talk about a penetrating injury to the duodenum. Hemodynamics are normal. The diagnosis is made. How do you manage that from a surgical approach?
Yeah, these are tough injuries. There's a lot of high-priced real estate in that area, and very often isolated injuries to the duodenum are not seen. There's usually other things that have been injured on the way in. However, fortunately, most of the duodenal injuries can be remedied with a relatively simple primary repair or a resection and reanastomosis. The injuries are graded according to the AAST organ injury grading scale, and we find that most of the relatively simple injuries we can, again, either debride to uninjured edges and repair primarily, or do a duodenostomy or duodenojejunectomy, depending on the extent of the injury.
So you've got a patient with a destructive duodenal injury, greater than 50% of the wall, second portion of the duodenum, medial wall and ampulla is spared. Is that one that we should fall back on pyloric exclusion or the classic diversion technique?
I really don't think that's necessary even in that setting. I think for those greater than 50% disruptions of D2, again, as long as that medial wall or that duodenoperineal pancreatic complex is spared, we can very often get away with a duodenal-duodenostomy or duodeno-jejunostomy or some sort of a more simple repair than what you're describing. I really don't think there's any role for that injury complex anymore for a pyloric exclusion.
On the general surgery communities, just this last week, there was a question about a lateral duodenostomy tube that raised its head from our history books. What about that? Did you ever use one of those?
I think if we find ourselves going back in for a leaking duodenal repair or a duodeno-duodenostomy that's fallen apart, that a lateral duodenostomy tube can be beneficial. And I've used them in that setting mostly in order to, at that point, I'm controlling a fistula that's developed. But I think utilizing a lateral duodenostomy tube for a first go-around, it should be avoided if possible.
Well, how about the duodenal hematoma? We had a couple of questions and a lot of discussion about management. So you've got an adult with a large hematoma around the duodenum. Everything else looks normal. The patient tries to eat and can't. What do you do?
Yeah, these are an unfortunate injury pattern, and if I recall, Dr. Weigelt, before you left here, one of your last patients had this going on. But we do see these pretty commonly in children with handlebar injuries on bicycles, but most of them, fortunately, will resolve without any surgical management. The mainstay of treatment early on is gastric decompression, and whether this is performed with a nasogastric tube or occasionally with a gastrostomy tube for long-term decompression, that's kind of the first order of business. The second thing to be sorted out is the patient's nutrition. For patients who are completely obstructed at the duodenum, they may need total parenteral nutrition for a while we wait for the hematoma to reabsorb. For patients who we can either endoscopically or fluoroscopically pass a feeding tube, then we can employ enteral nutrition while we're waiting for the hematoma to resolve or resorb.
One of the questions that the committee's had is, how long do you wait before you would try something different than observation and nutritional support in these patients?
These can take a fair amount of time to reabsorb, and I think giving them, first of all, I think going in too early can be detrimental, and I do think we probably don't wait long enough, whether it's because we as the surgeons are impatient or it's uncomfortable for our patients. It's tough to tell, but I think waiting on the order of 4 to 6 weeks may be necessary and not out of the realm of possibility for our patients, potentially even longer.
All right, well, let's move on. Let's talk about the pancreas. There's a few scenarios that were discussed on numerous occasions, and one was you have a patient with a seatbelt sign, and they have been worked up, and the only thing you find is a little fluid around the pancreas. The duct seems to be intact, and you've got this finding on CT scan. What do you do?
I think the critical piece there is that the duct seems to be intact. It is the most important piece of information in that story, and most of our pancreatic management or decisions are based around the pancreatic duct. If we look at the AAST injury grading scale for the pancreas, there's 1s and 2s don't involve the duct, 3s and 4s and 5s in some fashion involve the duct, and that's the big difference in management as well, because we find that for grade 1 and 2 injuries, or for injuries that don't involve the pancreatic duct, whether we find them on imaging or we find them intraoperatively, we don't need to do anything to those injuries. They will often heal on their own. Okay, so no operation, just observation, and advanced diet is tolerated for that patient? That's correct. Some of them will go on to potentially require a drain if they develop a fluid collection. Most of them won't. I do think it's important, though, that we need to be 100% certain there's no duct involvement, as you said. So if our CT is at all inadequate for determining whether or not there is ductal involvement, if there's any question, then we need to do some sort of more advanced imaging, whether it's an MRCP or ERCP at that time. But I think if we can confirm that the duct isn't involved, that observation alone is okay. You don't believe me when I told you it wasn't injured. You think I'm trying to throw you a curveball? Is that what you think? I think everybody is trying to throw me a curveball, Dr. Weigel. That's how I've made it this far.
Okay. How about you're in the abdomen for another reason, whatever it be, and you look down there and there's some contusion in the mid-body of the pancreas. What do you do then?
Assuming we've adequately mobilized the stomach and taken a good look at the pancreas, again, we need to assess for ductal injury. And if there's any question intraoperatively, I myself am not facile enough with doing intraoperative ultrasound, so I would not be comfortable doing that myself. However, in the middle of the night with limited resources, I personally would attempt to do a cholangiogram. I would take the gallbladder out and do a cholangiogram in the event that I may be able to get of imaging or visualization of the pancreatic duct that way.
Well, okay, you do that and there's no ductal injury. You're just looking at this pancreatic contusion right over the mid-body. What do you do?
Those patients could be managed without any further operation. They can be closed and we can move on. Again, there's no involvement of the duct. I notice some of my partners will leave a drain for some period of time. Depending on the extent of the contusion, I have left a drain in those patients. Usually I leave it in for about 96 hours or so. By then, my patients are eating. I will check the drain amylase and attempt to remove the drain at that point.
How about if there is a duct injury on that blunt injured patient and it's right over the spine? What do you do?
Those are tough injuries. The big management node in these patients is going to be the SMV. For patients with injuries to the left of the superior mesenteric vein, I'm going to do a distal pancreatectomy, and depending on how my patient is doing at the time, I may or may not make an attempt to preserve the spleen. Adding the splenic preservation to the case can increase the time and increase the blood loss from the procedure. And so again, depending on how the patient is doing, I may or may not take the spleen. For injuries to the right of the SMV, that takes a little more thought, and those injuries can be a lot more difficult to manage.
And how about the one, let's talk about the one to the left that you first mentioned, and do you do anything special to manage the pancreatic duct as you resect the distal pancreas?
I typically come across the entire pancreas with a stapling device, and whether we add a seam guard or additional mattress buttressing sutures or anything else, the leak rate appears to be about the same. And so I personally don't do anything different. I don't attempt to find the duct. This is a soft, relatively normal pancreas, and the leak rate is high. So I will staple across the pancreas, recognizing there is a relatively high leak rate, and I will leave a drain in these patients.
And typical stapler load, is this a large load or a skinny load? How do you make that assessment?
It can vary depending on how edematous or swollen the pancreas is. I've used either a blue or a white load. That is either a vascular or a tissue load or a GI load, depending on my assessment of the pancreas at the time, or how far distal I am, because that changes how much tissue is going to be in the jaws of the stapler. And
you said you leave drains in, so on the third day post-op, the drains are not producing anything. Do you take them out?
We'll check a drain amylase, assuming there's something to check. And if there's not much coming out and the drain amylase is normal on day 3 or 4, I will typically remove them.
All right, now you mentioned on the other side of the SMA, let's say you've got a through-and-through injury to the head of the pancreas. You look right through it and it looks like it's just below the duct. What do you do then?
Yeah, these can be extremely difficult injuries to manage. I think there was a time when there was a strong recommendation for the very extensive surgical management of these. However, in the modern era, I really don't think moving forward with either pancreatic duodenectomy or a near total pancreatic resection is appropriate. I think wide drainage and ERCP and stenting can go a long way for these patients and potentially avoid a much more intense operation. Now, if there is complete destruction of the pancreaticoduodenal complex or the ampulla or the distal common bile duct, then a formal pancreaticoduodenectomy may be necessary.
Let's move on to the liver. So you're fooled, and you've got a patient who gets operated on for hemoperitoneum, and you find a large stellate laceration over the dome of the liver. but it's not bleeding. What do you do then?
Well, I take a breath. Better to be fooled this way than fooled the other way. I think for these patients, assuming the remainder of my laparotomy is negative for other injuries, the biggest complication that these patients tend to have is the development of a myeloma or a bile duct injury that's kind of unrecognized from the mid portion of the liver that presents late. And so I will, again, depending on the nature of the stellate lesion, I've packed these with Omentum, with a tongue of Omentum if I can, in order to try and reduce the space and reduce the likelihood of post-op myeloma. But in general, if things aren't bleeding and the patient is physiologically intact, I'll close and move on.
So you don't stick your thumb in that laceration to put the Omentum in, do you?
No.
Oh, okay. Do you put drains in?
Depending on how deep those go, I have put drains in. However, I'm starting to second-guess this practice only because I've personally noticed that the development of the myeloma occurs several days after I normally pull my drains anyway. And so since I'm not willing to keep my drains in for 7 to 10 days, I'm going back and forth on whether or not I should even be placing them in the first place. So you've caught me at a transition in my career, Dr. Weigel.
Okay. Well, how about a blunt injury where you kind of look up there? There looks like there's a little bit of blood in the retroperitoneum, and you kind of take a look as you lift the liver, and you get a lot of bleeding, and now you're thinking, oh my goodness, I may have a retrocaval injury. What steps do you take to assess whether it's there or not as the first thing?
Well, as we talked about earlier, we were looking for triggers for massive transfusion protocol, and this would be one of them. It'd also be a trigger for me to call one of my partners in. But I think you can do a lot of damage by looking for trouble. Like I said, I think if you look for trouble in these scenarios, you can find it. Most of the retrohepatic caval injuries that aren't bleeding torrentially when we encounter them will heal on their own. And so for the patient you described, where when we manipulate the liver, it bleeds, but when we put things back or we pack the liver back in place, it is a little more quiescent. Those patients I will pack off with lap pads, do a temporary abdominal closure, and assuming there are no other major injuries that are driving me back to the operating room, I may not come back for a second look for upwards of 48 hours.
Good idea. A good idea. Now, what if you have the patient who, despite putting the liver back down, they continue to bleed? You got any steps then to assess and mobilize the liver?
Yeah, one of the first things we do, assuming we have wide enough exposure already, is I'm going to do a Pringle maneuver and get control of the portal triad. This can be done pretty expeditiously by putting your finger through the foramen of Winslow and pinching it, but I'll replace that with either a vascular clamp or a Ramel pretty quickly to free up my hands. Following that, I do like to get control of the infrahepatic vena cava in case I need to do a more drastic maneuver, and then I'll begin to mobilize the liver. One of the first things I do is get the appropriate retractors in place, because sometimes this is neglected early in a trauma laparotomy. But once I have adequate exposure, I'll begin to mobilize the liver and kind of move forward from there, depending on what vascular control does for me.
Now, we've talked about many of these patients being done in a hybrid room, or let's talk about it with endovascular techniques. Have you had any experience with that, or is this truly something that you can handle most of the time, direct approach of the injury in the operating room?
Endovascular techniques are useful. Not only can our IR colleagues access the arterial system and help us deal there, they are able to utilize some more advanced techniques, and actually they can go transarterial and get into the venous system and help us out. Our issue tends to be recognizing which patients will require an interventional procedure while we're still in the resuscitation bay. For us personally, utilizing the hybrid room requires a completely different team of surgical techs and nurses, and these folks aren't generally immediately available like our trauma room is. And so very often we find ourselves going to our traditional operating room first, getting control, and then going from there to our IR suite, which is actually quite close for if we need the assistance of interventional radiology.
And sometimes control is just repacking to get control of the bleeding. Is that fair?
That's fair, yeah. We can go ascend the ladder of surgical complexity from packing to non-anatomic resections to finger fracture and direct suture ligature, all the way up to hepatic exclusion or isolation.
I'm not sure we can go any further on this because each case seems to be a little different. Let's move on a little bit. And a lot of discussion in the literature from various institutions about the gunshot wound to the right upper quadrant with normal hemodynamics. The entrance is the anterior abdomen, and the missiles lying posterior to the liver in the retroperitoneum. And non-operative management is suggested. How do you feel about that?
I think we just need to recognize that we may be trading certain complications for other complications, and that needs to be okay with us. I don't know that we've shown a mortality benefit yet, but it is definitely a different way to manage these patients. I would caution people who are going down this road that I personally feel that evaluating the diaphragm on the right side is critically important, and so for our patients who've successfully made it through their first evening of non-operative management, we will often go to the OR the next day and do a right VAT and put a scope in the right chest in order to see if there needs to be a direct diaphragm repair. A certain percentage of the patients will go on to develop a myeloma, like we discussed earlier, and those patients will go down a different avenue of drainage and potential further diagnostic workup to see if we need to do something with the biliary tree. I don't think it's a bad way to manage our patients. I just think it needs to be done appropriately, and we need to recognize that there are potential pitfalls with this management as well.
How about the spleen? And the other committee discussion that was robust was the blunt injury with a blush in the spleen, but normal hemodynamics. Do you go to angio? Do you observe? Do you go to the operating room, take the spleen out?
I don't think option C is the correct answer at this point. I think for our hemodynamically normal patients, independent of their radiologic findings, I don't think we should be uniformly going to the operating room. So that leaves options A and B. Several studies have been performed which do show that if we take all of our grade 3 spleen injuries with a blush to the angio suite for either selective or non-selective embolization, we don't seem to reduce our non-operative management rate. However, there are some newer data that are emerging that suggests that maybe there are different types of blushes. Maybe not all blushes are the same, and that there may be a certain percentage of the grade 3s with a blush, again, depending on the nature of their blush, that should go for angioembolization. We recently pulled our own literature and have noticed an uptick in our grade 3s with a blush that have failed non-operative management. And so we are starting to put together a study trying to decide which of these grade 3 patients with a blush should go to angio and which have a high potential for successful non-operative management.
And once you admit them for observation, do you ever repeat any kind of imaging in these people with blushes?
So this is the other answer we hope to determine from looking at these patients that have failed, because we have had a few late failures from likely pseudoaneurysm. And so we are trying to develop a better way to predict who will go on to develop a pseudoaneurysm at risk for rupture. Very often, we will not reimage our patients. However, like I said, as we are seeing somewhat increased rates of delayed non-operative failure, we are attempting to determine which patients should undergo a repeat CT angio of their abdomen in order to determine the presence of a delayed pseudoaneurysm formation.
Let me push you a little bit. Do you think that the failure rates are due to improper selection initially, or do you really think this is a progression of the injury?
I think it's improper selection. I think what we're going to find, I hope, I guess, of what we're going to find is that there are certain characteristics of the blush, whether it's hilar or peripheral, or patient characteristics, potentially age, that will lend themselves to improved results with early endovascular intervention, whereas other patients may be just fine with observation alone. I think we've chalked up all of the blushes we put them all in the same wastebasket at this point, and I think that they are different, and it's up to us to figure out which is which.
Actually, there's a very old study that classifies them in the 4 categories that people have forgotten about, with an increasing risk of failure, but we tend to have forgotten about it.
We are using that as the basis for our study.
Okay, all right.
What is old is new again, I guess.
It comes around. The circle of life, or the circle of surgery. How's that? So, let's talk about rectal injuries. I think we've finally come to a conclusion about how to manage colon injuries, but I keep seeing controversy, and there was a lot of discussion in the committees about a gunshot wound to the pelvis, below the peritoneal reflection, hemodynamics okay, blood in the rectum. What kind of study do you need? Is this a need for a CT scan? Is this a need for a procto? What happens at your place?
So transpelvic gunshot wounds at our shop will get assuming they're stable.
Yep.
We'll get axial imaging. We'll get a CAT scan first. It helps us with trajectory, and I think it helps us with further management. There are other things that can be injured independent of the rectum in a transpelvic gunshot wound, and so I think axial imaging is an important first step. We do not give rectal contrast. I don't know if anybody still does, but if there's any question there, we don't. We have a 128 slice multi-detector CT, and according to our radiologists, giving intraluminal contrast, whether oral or rectal, actually decreases their diagnostic ability. And so they feel that IV contrast alone is the best study for all intestinal injuries or all intestinal pathology for that matter.
So you get that, you find a little bit of air and a little bit of fluid around the rectum. Do they get a procto, or is that something that's passé?
Most patients at that point, there was blood on the rectal exam, and given that trajectory and that air, they need some sort of anorectal study, and whether that's a rigid proctoscopy or a flexible sigmoidoscopy with a small amount of a limited amount of air, that would be the next step.
So you find an isolated rectal injury in the mid-rectum. What do you do?
Mid-rectum, I'm assuming that means it's not going to be approachable from the anus. It sounds like that's a little too high, and we're below the peritoneal reflection. So those patients, for me, are going to get a diverting loop sigmoidostomy. And depending on the nature of the injury or how devastating the injury was, we will study those patients in the hospital 5 to 7 days later. We find that most of the injuries were either minimal or have healed, and we will do an early reversal, same admission reversal for those patients. Obviously, if that study, that water soluble contrast study, shows that the injury persists, then we will send them home with their loop diverting ostomy and bring them back at a later time to reverse them, recognizing that most of these rectal injuries will heal on their own in time.
Okay, now the other argument was that everybody agrees that a distal washout acutely in the operating room when you make the diagnosis, do your diverting colostomy, was not necessary. But there was some discussion about whether the distal limb should be irrigated as the patient goes through their recovery. How do you feel about that?
I don't agree with that. I think that converts solid stool to liquid stool and has the potential for putting liquid stool in areas where it shouldn't be. And so I think the only surviving D when it comes to the 4 Ds of rectal injury is the diversion, personally. So
let's talk about the iliacs. And the first thing is, for somebody who doesn't do this day in and day out, you've got a gunshot wound below the umbilicus and they're hypotensive. Should they be taken immediately to the operating room, or do we need to image them or do something else?
Unless there's a word for faster than immediately, no, that is an injury that makes an experienced trauma surgeon's hair on the back of their neck stand, because this is going to be a periumbilical gunshot wound with hypotension, is a bifurcation injury until proven otherwise, and it may be a combined arteriovenous bifurcation injury. It can be an extremely difficult injury to manage acutely, and carries a very high mortality rate with it.
Okay, well, you're exactly right. So what you do is you go in, you operate, you find a common iliac vein and a common iliac artery injured on the right, right at the bifurcation of the aorta. And you're quick, you get control. Can you ligate the common iliac vein based on the location of the injury?
That can be ligated there. Yes, through the gonadals and some of the hemorrhoidals, there's enough collateral that we can ligate the common iliac in that spot.
Okay, and you also notice there's a cecal injury, there's some small bowel injuries, and you're going to use a damage control approach, and you want to use a vascular shunt. So what do you use for the common iliac artery?
So the largest commercially available shunt that we have immediately available to us in the operating room is a 14 French Argyle. That can be a little small for the common iliac. Now in some younger women that may be adequate. For men, however, moving up to a small chest tube, moving up to an 18, sometimes even a 20 may be necessary. However, oftentimes the arteries are spasmed, and we can get away with, like I said, sometimes it's something in the 16 to 18. I will caution when we make our own shunts out of some other piece of plastic, like a modified chest tube or a modified feeding tube, they don't have a nice blunted, rounded tip like the commercially available shunts, for instance, the Argyle or some of the other ones available to us. And so I would caution the crew that you don't cause an intimal injury inserting any shunt, but especially inserting a homemade shunt.
The Argyle shunts are heparin bonded, are they not?
I believe they are.
And so when you use a chest tube, do you have to worry about clotting of that shunt?
No, there's enough flow through the shunts that they will stay patent without a heparin bonded shunt or without systemically heparinizing our patients. They'll stay open for typically as long as we need them to. There is a risk that they can go down during our resuscitation period. However, there is plenty of evidence to support leaving a shunt in place for 12 to 24 hours. I believe there was a soldier who had his shunt in place for 54 hours, and that was written up as a case report, and it was still patent when they finally got him where he could undergo definitive repair. Okay,
and so you're successful, you resuscitate the patient, you bring them back at whatever time, and you're going to do your vascular repair. You've had enteric contamination in the abdomen. You've got a defect that's about 3 centimeters in your common iliac artery. What do you use as a piece of whatever to bridge that gap? Is this someplace where you can use a prosthetic graft, or do you have to harvest a autogenous graft? And if you're going to harvest, where do you go to get one that is a good size match, not for that young lady, but for the young man?
Yeah, I think what you're getting at is that we know that just a straight reverse saphenous vein up in the iliac is going to be too small. There is evidence that we can put a piece of synthetic graft, usually Dacron, something that's going to incorporate a little bit. Even if there had been contamination previously, it's not ideal, but it is doable. Alternatively, the patients can have their vasculature diverted in an extra anatomic way. They can have a fem-fem from the contralateral extremity to make a piece of autogenous vein big enough for the iliac. We may have to do something larger like a spiral graft of sorts, but I think most people would be okay doing a Dacron graft in the setting that you described.
What about the internal iliac vein on the side that you've ligated the common iliac vein? Is that something you could do, or does that create some problem with collateralization and venous return?
No, the hypogastric can be used. We can basically kind of flip the two vessels, flip the external-internal around, and utilize the hypogastric artery or the internal iliac as a conduit. But this can be done. It requires a certain amount of vascular experience and technical skill, but sacrificing the internal iliac carries with it a relatively low morbidity risk. We do this with some regularity in the setting of severe pelvic trauma.
Well, let's move on and you've got your military and civilian experience in a trauma situation. So what's your take on this device we now call Reboa, especially how it should be applied in civilian trauma centers?
As so often occurs, we have a new piece of technology and we're trying to figure out the best way to use it. That has not been answered yet. For listeners that aren't familiar, Reboa is nothing more than a balloon occlusion device, which has the unique ability to be placed without a long guide wire or a sheath in place. It can be placed directly through a percutaneous approach into the common femoral artery. The described uses have been for either intra-abdominal or massive pelvic trauma, basically any major trauma below the diaphragm. I think Reboa will have a place in major trauma centers for pelvic trauma. It offers us immediate surgical control of arterial pelvic bleeding, and that in combination with something like extraperitoneal packing or pelvic fixation, which will attempt to control the venous bleeding, will allow us to get earlier vascular control from pelvic trauma. In the setting of abdominal trauma, however, at a well-oiled trauma center where we can get somebody to the OR and have their abdomen opened in under 10 minutes, I'm not sure I see the future for Reboa for abdominal trauma. I know I won't make a ton of friends by saying that, but from our limited experience here, and maybe it's because we're not that facile with it, but if you look at Dr. Brenner's data, for instance, where she describes getting access within 5 minutes, I think that's fantastic. But at my institution, I can get into the abdomen in 8. So I think here I would prefer to be in the abdomen. Now, that said, if I was at a level 2 trauma center or a level 3 where my surgeons were 15 or 30 minutes away, there may be a use for earlier balloon occlusion of the aorta, potentially placed by surgical residents while they're waiting for their faculty to come in, or by EM faculty while they're waiting for the surgeons to come in. There may be a use there in the future. I don't think we've really teased that apart yet. As far as field Reboa or placement of Reboa pre-hospital, I think that's very, very far away, and I really don't advocate that at this point. But I do think it's important to recognize that the Reboa is the first step in an operation. It's not something separate. Once you've occluded the aorta, it's the same as placing a cross clamp, and that should be done with the intent that you're immediately going to surgery afterwards. I've told my EM colleagues and anesthesia colleagues that once you see that Reboa in, that the case has started. It's part of the operation. It's not something to be looked at separately, and I think that's an important distinction to be made.
I hope our audience appreciates your refreshing common sense approach to this new device. The other thing I will add that in a couple of the committees we had a robust discussion about its use by obstetrics for severe uterine hemorrhage associated in the peripartum period and there seems to be more reports of that use, and that, who knows, the device may transfer from the trauma surgeon to the obstetrical surgeon.
Yes, we've done this a couple of times here for elective placenta accreta deliveries, which I had to do a little research myself, but oftentimes these cases have more blood loss than some of our worst trauma cases, on the order of 4, 5, 6 liters of blood loss with massive transfusions. And what we have developed is a co-management pathway here where we will join our obstetric colleagues in the operating room during times of delivery, knowing that there's a placenta accreta. We will place the Reboa for them, and we will stay in the room and not only manage the Reboa, but we are also available for surgical vascular control, and we're able to help out with the massive transfusion itself.
Let me finish this up today, David, by asking you to make some comments on the military-civilian coalition that's being developed for ongoing experience of our active military. I know you're part of it. You want to maybe give us a little bit of an overview and your experience so far?
Certainly. The military-civilian partnerships are not new. We've had several in place in our country for quite a while. What has been recognized is that our DoD hospitals, our military hospitals, do not see enough, not only major trauma, but major operative cases to keep our active duty surgeons trained in between periods of conflict. And what's been talked about, and the Pandemic All Hazards Act has been signed off by the House and the Senate, and as well as the President. Basically, it allows for or encourages military-civilian partnerships at a very formal level. And so at our institution, just like at Oregon Health Science University or Cooper and a number of other universities, we now have an active duty surgeon who is credentialed and is part of our faculty, but he is basically doing his tour, his 3-year tour here. So he remains an active duty soldier, active duty surgeon, and he is one of our partners in the interim. And so while he's here, he's fully staffed and fully accredited to do cases and to get experience. He is not shadowing us. He is not being watched over us by us 100% of the time. We respect him as a fully trained surgeon, and he is here to gain experience on some of the cases that he may not see at his own active duty center. It's been a great experience so far, and I think it's important to see that there's two-way learning. So not only is he coming our way to do cases and to learn from us, but we are actually learning a lot from him. He is able to teach my other faculty and our residents about operating in austere conditions and just be able to approach trauma in a different way. So I think overall it will be beneficial to everybody, and I really hope that these programs last and are durable. I will say that the bill has been passed and signed off by the President, but it hasn't gone through appropriations yet. And as money tends to drive everything, it will be important that this program gets funded in the future. So for any listeners that are interested in advocacy, a phone call to their senator or congressperson would be extremely beneficial in ensuring that this program goes through appropriations and gets funded appropriately.
Excellent comment, and also the idea that a partnership should be two-way learning, and I agree with you completely. My experience has been it's always a two-way street. So, okay, well, David, I really appreciate you spending time with me this morning. And I really appreciate your contributions to CSAP. But as with all my authors on Audio Companion, I give you the opportunity to make any kind of comments you want about the CSAP process, about the Audio Companion. So you've got the floor.
I think this is a fantastic product. Not only am I a contributor, but I'm a user. I learn so much every time I read through my newest edition of CSAP, or every time I interface with the other authors of the text. And one of the most important things what CSAP does is that it really forces us to not only stay current on the literature, but to not be swayed by massive swings in practices. And we really do see the pendulum swinging back and forth both ways, and to really not make drastic changes in our practice just because one or two institutions are putting out some new data. So I think it's great. Not only that we have the experience of yourself and your authors, but also the forums that you entertain and the questions that we get from the audience that really keep us honest and keep us working harder and developing better and better questions and pulling better and better articles. I thank you for everything and for the opportunity to be part of it.
Thank you, and once again, I thank you for your contributions, because without all the authors, we wouldn't have a product.
Thanks a lot, Chuck.
That's it for this category of the CSAP 17 Audio Companion.